Please listen carefully.
Hello, Team Anaesthesia. Welcome to GasGasGas. This is the best anaesthetic science podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. Now, you might be in the gym right now, commuting, or ironing your scrubs, and there's no judgment here. GasGasGas will prime your brain for the monsoon of knowledge you need to imbibe. But regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Now remember to check out the website, that's gasgasgas.uk. There are show notes there with all the detail, plus links to foundational reference papers and anything else useful I find for you guys. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone and welcome to another episode of Gas, Gas, Gas. Naturally, it's been a bin fire of disorganisation over these past few weeks because of holidays, life, etc. So yet again we're coming to you a few days late. But nevertheless, we have a humdinger of an episode. We have Martin returns from Sweden for his third out of fourth Viva sesh. He gets quizzed for 30 minutes, which obviously is quite a bit longer than the Viva, on approaching a appendicectomy in a 12-year-old lad and managing a intraoperative emergency. He obviously approaches this with the grace and aplomb that we have come to recognise him for, but nevertheless, thinking about how you will do this yourself and your approach and some of the clinical tidbits to pick up are certainly of benefit. Sit back, tuck in, start running, do that ironing, and we'll get on with it. So we shall welcome Martin to his clinical Viva, and we are hearing that the surgeons have a spot of work for him, and the surgeons want him to go and see a 12-year-old boy, which is perhaps quite topical for your career choice, who's presenting for a laparoscopic appendicectomy. He's got appendicitis. He's got a history of hay fever. He has no allergies beyond pollen. He's otherwise a fit and well child, no other medical issues. What are the key elements of the pre-assessment that you would wish to identify before going about managing this case?
So the key elements of the pre-anesthetic evaluation of a 12-year-old boy who's at the A&E.
Say he's on the ward.
He's on the ward, right.
Emergency theatre's been proper busy. He needs his appendix out.
So this is your standard pre-anesthetic evaluation. I would start by taking history, and my main questions are regarding whether he's had an anesthetic before, and also whether his first-degree relatives have had any anesthetics. This alludes to the risk of him inheriting a risk of MH, basically. And then the physical examination would constitute his airway, as in Mallampati grading, as in a environmental distance grading, as in moving his neck back and forth, and his teeth, his current dental status, so to speak, and mandibular joint flexibility, I guess I could call it. Then listening to his heart and lungs, I bet I'll find nothing. A 12-year-old stressed with appendicitis could absolutely have a systolic murmur, but that would not make me question his cardiovascular abilities. And then questioning whether he has been nauseous, has he been eating, has he been vomiting? Is he such a person who has a lot of nausea whilst going about in the car, stuff like that. And then I'll sort of, as I go about doing this, I will sort of put him on a scale from completely terrified to completely calm. Do I believe this child will need any pre-medication? Can we place an IV, do an IV induction, or do we need to go down the inhalational induction route? And also where he sits in his appendicitis disease. Is he straight up septic, or is he just one of those who has almost normal biochemical findings and a slight fever? Yeah, I guess that's about it.
What would your approach to consent be in this situation?
So for a 12-year-old, I would inform him and speak to him as if I was talking to an adult almost. Most 12-year-olds, I believe, can handle that. But for formal consent, his mother or his guardian needs to approve of the surgery. In Sweden, one parent needs to approve because it's not usually feasible for both to be present at the hospital. Is it different for you? No? You need both parents?
Yeah, so we have this thing called GILIC competence, which is if a child seems sensible and able to have an appropriate conversation, we might consider them competent to consent to surgery themselves. They can't refuse a sensible intervention, though. So if they needed their leg off because it was rotting to bits, and they said no, then you'd just turn to the parents and be like, can we take the leg off? And they'd be like, yes. And then obviously it'd be very challenging to anaesthetize the child who doesn't want the anaesthetic, but legally that would be how it would stand. But in general speaking, you would have a conversation like you've mentioned with child and with caregiver, and explore and explain, and then explain, the side effects and complications of anaesthesia, and say, have you got any questions? Do you agree? Shall we crack on with it? Is the approach that would generally be taken. So you've assessed that. He's appropriately starved. From a sepsis perspective, he's sort of in the middle. He's not floridly septic and possibly having a perforated appendix, but he's not just like running around the ward and the surgeons are like, well, let's take it out. He's a little bit sick and nauseous. He's off his food. He's had a previous anaesthetic when he was really little to have a cut stitched up because he banged his head when he was small. And that's him. So talk me through how you would approach an anaesthetic for this young man.
So after going through all this and you receive the information provided, I would go for a intravenous induction should he cooperate to IV placement. And the way we do it is that the mother is present during, which is nice. It calms the kid because and I would have him. So from the start, I would draw up all my medications, and I will make sure I have a theater with personnel who are comfortable with pediatric cases. I would have pre-calculated my dosing. I did not catch his weight, but it's all the dosing is weight based, and a 12-year-old, I bet he sits around the 35 kilo span somewhere. Yeah.
35 kilos, yeah.
So I would pre-calculate my dosing. I would pre-oxygenate with a tight mask seal as long as he approves of it. To me, I'd rather have a calm kid who's not crying his lungs out as opposed to being forcefully pre-oxygenated. I would induce him with propofol first, not the usual opioids. The way we do it usually is give the opioids, ask the person, do you feel it? And then here comes the propofol. But for kids, I usually do the propofol first because it's just a smoother induction. Some find the fentanyl or whatever not very pleasant. So I would induce him using propofol. I would use the dose. The dose would be somewhere around 3 to 4 up to 5 milligrams per kilo until he's appropriately under. I would pick a short-acting opiate, either fentanyl or alfentanil, because it's going to be an RSI case. So after I push my propofol, I'll assess his state of anesthesia, and then I'll give him a bolus dose of fentanyl. After that, the non-depolarizing muscle relaxants will come. I will give him rocuronium at a RSI dose of 1.2 milligrams per kilo. Sorry, the fentanyl has to be about 2 milligrams per kilo, I think. And for the airway, he needs prompt intubation 90 seconds after the rocuronium has left the syringe, and I'll have an IV running during, and then I would maintain him on sevoflurane after endotracheal intubation, making sure I turn up my sevoflurane as soon as the endotracheal position of the tube has been confirmed using capnography, auscultation of the chest, bilateral movement of the chest, and hopefully a little bit of a mist in the tube.
Cool. Okay. And you've mentioned maintenance with sevoflurane. What other drugs would you give him during the case?
So maintenance with sevoflurane would call for some sort of analgesics during. So for laparoscopic procedures, I usually give a big dose of fentanyl right before they put their ports before insufflation, because that tends to be painful. I would put him at a MAC at around 0.91, and then I would give him boluses of fentanyl as we proceed. Is it a shorter case, then for the initial fentanyl bolus for induction, then another one at start, and then some sort of longer acting opioid at the end. We usually go with 0.1 milligram per kilo of oxycodone. For multimodal analgesics, I want him to receive paracetamol as well as an alpha-2 agonist, which also, we usually do that. We give clonidine at 1 microgram per kilo, I believe. It also sort of smoothens out emergence, in my experience, especially from sevoflurane.
Yeah, emergence delirium being your concern.
And it also potentiates the opioids. I'd like for him to have both ondansetron and a dexamethasone dose to prevent post-operative nausea and vomiting. I think that's about it. Yeah.
And what's your approach to extubation for this young man?
For a 12-year-old RSI, I would extubate him quite late, or he will be, for a 12-year-old. I want him to be awake. Basically, I want to see him swallow. I want to make sure he's regained his protectiveness of his airway, making sure he establishes a train of 4 count that is comfortable before removing the endotracheal tube.
And when you say comfortable, what's your goal with that neuromuscular monitoring?
It's above 0.9, but I'd rather have the machine tell me a actual percentage number. I know so it's above 90%, but I would say like usually it ends up being well above 100 for some reason. Knowing that you can perform, like you can have 90% on the train of 4 and still have, I believe it's 60 to 70% of your poor acetylcholine receptors still blocked.
So what's your approach if say, for example, their train of 4 was less than 0.9 and it was 0.5? What would you do?
And we're about to leave the operating theatre.
Yeah, we need to extubate him. They're finished. The surgeon's gone.
Because the next patients come in. I would, for a 12-year-old, I would give him, where we're at the moment, with the Sugamadex now being off patent, I would give him Sugamadex. And you said his train of 4 count was
0.5.
0.5, I believe, mandates a dose of 2 milligrams per kilo, because it's in relation to how deep your block is.
Absolutely. And you've still got 4 twitches, but it's just 1 versus 4 is a bit feckless. Yeah. Cool. And you mentioned swallowing. Are there any other particular objective criteria you would consider before extubating a child?
Breathing.
Yeah.
He needs to be producing tidal volumes on the anesthetic machine before. Swallowing is good, but breathing is more important.
Breathing is important. I agree with you, doctor. Okay. So now to sort of bring us back into the middle of this operation, you've given some fentanyl, you've given some clonidine, but you've noticed that there's a progressively escalating airway pressure and your tidal volumes are just sinking off. It's becoming harder to ventilate patient. You can see CO2, the heart rate is 95, the blood pressure is currently 95 over 68. It was 109 over 58. What is your approach to assessing this situation?
The situation is increasing ventilatory pressures and lower tidal volumes. I would administer 100% oxygen to start with, for the patient not to fall off the respiratory bandwagon, so to speak. I would go so what I normally do is I go from patient to apparatus, making sure that the endotracheal tube is not in the right mainstem bronchus or has been kinked or anything like that, and then checking all the tubing all the way back to the apparatus. If that's fine.
And it is fine in this situation.
All right. And I auscultate the chest for wheezing or bronchial non-wanted sounds.
And you hear widespread wheeze.
Widespread wheeze. Okay, so I would consider this a bronchospasm. I would not, as of yet, maybe declare an emergency because it's not in a circulatory collapse situation, but I do have in the back of my mind that this could be an anaphylaxis. We're not supposed to say anaphylactoid reactions anymore. I would administer more sevoflurane because that's a great bronchodilator. I would consult my quick reference handbook and inform the surgeon as well as the anesthetic nurse. And I'll administer. I'll administer a beta stimulant through the breathing circuit. I think that's what I would do. If it's not a cardiovascular demise, then I would go down the anaphylaxis route and give him adrenaline.
Anyhow, time for a brief mention about the sponsors of GasGasGas, Teach Me Anaesthetics. These guys are behind an excellent single best answer question resource. Firstly, I took the joyful, challenging and intermittent bashing through their 1100 plus questions which they have written for the FRCA primary exam. Now I secretly loved it and there are plenty of questions to test your knowledge. When I was studying for the FRCA primary, it did not exist, but there were other packages online. These cost a lot more and they didn't really seem to reflect the content of the exam. exams. Whilst doing them, I came across rehashed MRCP questions, which was not terribly inspiring and left me pretty cheesed off. Whereas these single best answer questions have been built from the ground up. They have not sniffed an MCQ in a past life. They are based on the anaesthetic science you need to know, and there are explainers with all the questions, so it builds your knowledge as you work through them. There is a multitude of ways you can study these questions. You could choose to do a random battle with 1100 plus questions, or split them into subject area. You can go back and redo the ones you've gotten wrong. It's very malleable. So if you've been thinking about which question resource you might want to get your hands on for the exam, you shouldn't really look any further than Teach Me Anaesthetics. If you reckon it's for you, all the links to Teach Me Anaesthetics from GasGasGas are affiliate links. So if you're signing up through one of those, you're helping to support GasGasGas. So if you think you're going to go for it, click a link with me. You know you want to. You'll not only be supporting your exam preparation, but you'll be supporting your 100% favourite Tell Your Nan Over Sunday Lunch podcast, which is, of course, GasGasGas. Absolutely. So what is, just before we go any further, what is your differential for high airway pressure? You've mentioned circuit issues. Anything else that could cause it?
So high airway pressures, circuit issues, but also light anesthesia, like him opposing the ventilator. We were talking about differentials for high airway pressures doing anesthesia of a 12-year-old healthy boy, I believe. So we mentioned circuit issues. We mentioned light anesthesia and bronchospasm, either an isolated bronchospasm in someone who's sort of asthmatically prone, or as part of a anaphylaxis reaction. Other reasons for high airway pressures. No, I'm fresh out of ranges. There's the I was thinking about something, but it's escaped my mind. Sorry.
We'll come back to it. Okay, excellent. So you've auscultated the chest. We know we've got a wheeze. You've increased the dose of sebeflurane, and you've administered a beta agonist through the circuit. Presumably that's salbutamol or something to that effect. Yeah.
We call it Ventolin.
So it's not done much actually. And the SATs, you're on 100% oxygen. Your SATs are now 90. What else can you do to try and break this bronchospasm?
I would now administer adrenaline and declare an emergency, call for help, because 90% saturation at 100% FiO2 in an otherwise healthy patient shouldn't be the case. I would inform the surgeons and also have them desufflate the abdomen so that my airway pressures can. I sort of forgot that we were in a laparoscopic situation. They'll need to desufflate the abdomen for my patient's lungs to expand.
So we mentioned adrenaline, salbutamol, any other bronchodilating agent?
There is theophylline, but it's a slow-acting one. I could also administer ipratropium bromide, I believe. It's called Aeromir, but that would have to go in the circuit as well, and it's a bit cumbersome. I could give beta agonists intravenously as well.
Yeah, and if they're not ventilating easily, anything else in your anaesthetic cupboard of tricks that might bronchodilate?
Ketamine, like a magnesium, right? I did not have ketamine.
Yes, and magnesium.
Ketamine seems as if it's never wrong.
Yeah, basically, if in doubt. Although the issue with ketamine in this situation is it increases bronchial secretions and siluria, which might make your ventilation strategy more problematic. So we've spoken about approaches to break the bronchospasm with drugs and volatile anaesthetic agents. Are there any alterations to your ventilation strategy that might improve the situation? You've mentioned desufflating the abdomen. Any modifications to your ventilator?
Modifications to my ventilator, I would have to assume that we are in pressure control volume guarantee modes, and for that, that's usually what we do in my institution. For that, I would allow higher pressures to reach adequate tidal volumes, but I could also increase the respiratory rate so that my minute volume is adequate. However, that also puts strains on the lungs in the form of the total mechanical work being exerted. I could prolong the expiratory interval or in the ventilator so that my inspiration to expiration relationship is longer.
Mm-hmm. What benefit does that have?
It makes for the expiration to proceed for a longer period of time. Exhalation. If the patient is very bronchospastic, the smaller airways collapse upon expiration, and if you keep expiration longer, you can have more volume leave the chest.
And what might happen if you increase the respiratory rate too much?
I run the risk of stacking breaths. So I need to keep track of my flow indicator on my ventilator so that the flow reverts back to zero with each breath. What I could do in this case is just disconnect the whole apparatus and sort of manually compress the chest if I was in a situation where I think that the intrinsic order PEEP has built up so much so that it has an effect on venous return to the heart.
Absolutely, yeah. Yeah, you'd notice a drop in blood pressure. Excellent. And with these high ventilatory pressures, what complications may occur?
So you run a risk of pneumothorax, especially when they desufflate the abdomen, because then the pressure from the abdomen is no longer opposing your ventilatory pressures. But you also run the risk of injuring the lung from the shearing forces of high driving pressures. So that's the difference between your end expiratory pressure and your inspiratory pressure.
Mm-hmm. Your PEEP, I think we call it in the UK PEEP.
Yeah, so PEEP from PIP.
PEEP, yeah.
Or PEP. PE, yeah. There's the PIP minus the PEP. That will give you the driving pressure. And there is some indications that having a high driving pressure is bad for the lungs.
Yeah, potentially injurious. I had one more question. PEEP in severe bronchospasm. What options do you have there, and why might you pick them?
So in bronchospasm, you'd need to balance PEEP against your tidal volumes so that you actually get tidal volumes. I would say that you still want some PEEP because you want to ventilate closer to your FRC. So PEEP is, in bronchospasm, as in any ventilatory situation, PEEP is a double-edged sword in that it's sort of too high, too low a PEEP would give you would not optimize compliance of the lung, whereas too high a PEEP would hinder venous return to the heart. It also affects your pulmonary vascular resistance in that the balance between expanding and elastic return forces, they are most optimal at the FRC, keeping the pulmonary vessels nice and round, not flattening them as you stretch the lung.
And you mentioned intrinsic PEEP. Just tell me a bit about that.
Intrinsic PEEP is the pressure is the pressure at end expiration that is due to the patient it's himself, sort of. So it's not a pressure I'm applying, but it's a pressure that is building up within the lungs due to a valve effect almost.
Yeah, narrow bronchioles expose the alveolus to an intrinsic degree of PEEP that you have no control over, so that there's a degree of resistance to expiration at like the bronchiolar level. Interestingly, once upon a time, the ventilatory management of severe asthma attacks, everyone was like, oh no, don't do PEEP. And actually now there's some suggestions, and there'll never be any research evidence on it, but trying to match intrinsic PEEP to your extrinsic PEEP might splint those smaller alveoli open and give them an opportunity to empty, as long as your expiratory times are long enough. There was a patient one of my colleagues was treating, and they just had a crack at sticking NIV on or CPAP with some PEEP to someone who they really didn't want to intubate, and actually their work of breathing got far, far, far better, and they settled down because they were able to empty those alveoli that they were struggling to empty. I think patient dependent, worth a crack. If it doesn't work, you undo what you did and hope that it doesn't get worse.
As long as you don't have to put them on the ventilator.
Yeah, well, because ventilation's like everyone, you're in A&E or emergency room, there's an asthma exacerbation, everyone thinks, oh, they've intubated them, they're fine now, and walk off, and it's like, there's just more problems now, not less problems. Yeah, I think people don't realise that, do they? Terrifying. Proper bad asthma. Cool. Those were most of the things I wanted to cover. I think we would have ended up speaking for eons. I suppose the thing I wanted to maybe touch on is, what if it's not getting better? What would you do if it's not getting better? Because they're probably going to ask you, if it's a clinical exact question that's quite long by the sounds of it, they'll probably want pre, intra, and then disposition and post, or like the things you would tidy up afterwards when this emergency had happened is probably going to be a part of a question. So what would you do if it wasn't getting better?
So I would repeat my adrenaline dosing and basically until I see an effect, and then move over to an adrenaline infusion, and I'll have the surgeon stop the operation at a safe point. Obviously, they can't have stuff left in the stomach, but we'll have to find some sort of middle ground, and then we will move from the operating theater into the intensive care unit, and try to focus on ventilatory strategies that works alongside adrenaline treatment. and fluid resuscitation. And then there is the matter of diagnosis, and for this, you need to take the tryptase, I believe, and I think you should do that ideally, it's like within 90 minutes, but as we spoke about before, time tends to pass really quickly in these scenarios, and then refer to allergy testing once everything is sort of cleared.
Yeah. The other thing maybe to think about is you're taking them to critical care. You're probably going to have to turn the sevoflurane off, so things might actually get worse, not better, during that journey. And then the other thing just like icing on the cake, is that you go and talk to the family and explain what's happened, explain what you've done and why. And you could ask the surgeons for this sort of case, an open procedure might be what's necessary to, tie off the stump and get the appendix out and get out of Dodge in a non-prolonged state, depending on where they are in the case, isn't it? And that's something to address, hopefully, when you've got a degree of control. Lovely. So how did that feel? That was quite a long conversation, actually.
It was a long conversation. For the clinical part, I feel a lot more comfortable doing the clinical vivas rather than doing the physiology, pharmacology, physics vivas. And I guess that's inherited to having worked for 5 years in the field. Like, I've seen and done these things, and I can sort of reason myself out of most issues, I think.
I think the one question that caught you was the differential for high airway pressure. And you had a degree of structure there because you thought, okay, is this a ventilator issue or a patient issue? But you should probably subdivide the patient into, is it a surgical problem, i.e., is it because they've insufflated the abdomen far higher than they ever should have done? Or is it a bronchospasm anaphylaxis issue? Or actually, is there another reason why high airway pressure could be coming about? And pneumothorax would be the other one to remember in that situation. There are some very rare case reports of like a bung being stuck in the endotracheal tube, and sometimes endotracheal tubes kink and no one notices, and then you go to look at the tube and you straighten it out without even thinking that there was a kink there in the first place, and it all gets better, and then you go and do something and it all gets bad again.
I think that's my primary differential. I can go from patient to machine, but the pneumothorax I failed to mention.
But otherwise, yeah. And pulmonary edema, but in a 12-year-old, unlikely. And that would have to be like really bad pulmonary edema to lead to massive airway pressures. It'd have to be quite florid. Doesn't really fit with the clinical situation at all.
Surely you should notice that within the endotracheal tube as well. Like, it would be pouring out of the...
It would be really, really bad, wouldn't it? Yeah, absolutely. And we called for help. We gave loads of oxygen. And yeah, I think when you're thinking about the drugs, and sometimes in these situations, it might be worth just saying, so bronchospasm, and briefly describing the pathophysiological problem, because that might help frame your mind into thinking, well, okay, so as a target for drugs, but also should I alter my ventilatory strategy to give myself a better chance? And then drugs-wise, you could probably break it down into common drugs to use and then less common drugs to use, and that might help you think about the salbutamol, or the Ventolin and the ipratropium, and then like magnesium probably would work really well. In the UK, it's Smarties. It's just used left, right, and centre for a bunch of things, and definitely quite commonly used in asthma exacerbations. And steroids, it's probably worth getting some steroids in them. Not that it'll make an acute difference now, but in 4 hours on ITU, it might help settle things down. So break it down to like common or catecholinergic drugs, and then slightly weirder, wonderful things like, you mentioned volatile, and that's absolutely fair game because it's definitely a bronchodilator. But then magnesium, ketamine, aminophylline, and then steroid. I can't think.
Is aminophylline your theophylline, right?
Yeah. So theophylline, I think is the oral preparation. Aminophyline's the IV preparation. But you're going to see a rip-roaring tachycardia with that, like you are with adrenaline, like you are with the ketamine, like you are with the salbutamol. And not quite. I've got the quick reference handbook up for UK anaesthesia here. It could be that the stomach is really full of gas as well, especially earlier in a case with a kiddie if they're a bit awkward to ventilate. So it's not, I'm going to save their life with an NG tube, but it might be worth sticking one down when there's an opportunity just to decompress it, just in case. The surgeon could probably tell you that as well, because they'll moan at you. They're doing laparoscopic surgery and the stomach's full. Fun times. And yeah, pneumothorax, but you've listened to the chest. I suppose you just have to repeatedly listen to, make sure if there's a change, you explore the change. And that's it. That is everything I've got for you, Martin. So those folks interested in having a bit more of a read and a think about emergency care for asthma, there's a really good EM Crit podcast episode and a web post from Scott Weingart all about that, which does dip into that exploration of intrinsic PEEP matching with extrinsic PEEP from the ventilator and how the mechanics of that may have benefit. I wish to robustly caveat that is, a slightly newer approach to ventilating these critically ill, very hard to ventilate asthmatics, and it might raise some eyebrows, so it's something to suggest as opposed to dive into. And on the topic of intubating them, and I'm sure no one actually really wants to intubate the truly devastatingly bronchospastic, can't breathe, collapsing 18-year-old with rip-roaring asthma. And thankfully, it is a very rare event because magnesium, IV salbutamol, aminophylline, maybe, etc., does do a very good job of breaking bronchospasm. The downside to all those drugs doing a wonderful job is that we have less experience managing it. So I'd make sure that you all have a read if you've not got that degree of familiarity, so that if it happens, you aren't working from having absolutely not one single iota of a Scooby-Doo, but you appreciate that whilst everyone else thinks that sticking a tube in a trachea makes everything better, it in fact makes everything a million times worse. And you need to contend with the potential for that positive pressure ventilatory attempt leading to a loss of venous return and brief cardiac arrest, the inability to ventilate them, the need to have exceptionally long expiratory times. That might mean that your pH really does go up the wazoo, being ready to treat an acute pneumothorax that obviously would make your life much worse yet again, and potentially, as Martin said, disconnecting the circuit and actively expiring by pressing on the person's chest and locating the kitchen sink and throwing it at them to try and achieve a break in their bronchospasm. And this is why most of the hospitals in the region I work in do have a ventilator with sevoflurane available, because it is an excellent bronchodilator. It just happens to anaesthetise you, so obviously it's not first-line therapy. Anyway, have a lovely week and see you in 2 weeks' time for Martin's final foray into Ahoy, physics.
Team
Anaesthesia! You've survived yet another episode of Gas, Gas, Gas. Now, if you found it useful or harrowingly awful, please like and subscribe, drop us a star or 12, and follow with whichever podcast platform you find yourself using. Please leave a comment or ping off an email if you think I need to square something away. Now, there are a bunch of ways to support the costs of Gas, Gas, Gas. From buying me a coffee, to venturing forth via an affiliate link to the horde of joyful SBA questions from Teach Me Anaesthetics. Those links are on the website and in the show notes. Speaking of website, definitely check out gasgasgas.uk for the show notes, diagrams, details, the references. Now, we all know, guys, that this is a bucket of content to consume, and it is like drinking from a fire hose. So I want to finish by saying, take it day by day, don't overcook yourself, don't freak out, and keep studying.